Hi, I'm Christine Albert. I'm from Cedars-Sinai Medical Center, and I have the pleasure of being here with Lena Rivard from Montreal Heart Institute. And she presented today on the Brain AF study, really interesting study that garnered a lot of attention at the Late Breakers. So first we're going to start off with you telling the audience a little bit about the results. And
thank you for having me. So the Brain AF trial, randomized patient to rivaroxaban or placebo, patient with atrial fibrillation and no indication of oral anticoagulation. So it's a very young population with no stroke risk. Those people don't have any indication of anticoagulation right now. So what we wanted to do is to see if oral anticoagulation would decrease the cognitive decline in this population, because we know that even in young patients, atrial fibrillation does increase the risk of cognitive decline. So that was the purpose of the trial.
Yep.
So the results, the trial was stopped early by the TCMC for futility after a mean follow-up of 3.7 years. We didn't find any differences between the two groups on the rate of cognitive decline. So that was the result. And, but we saw a huge rate of cognitive decline. So in the whole population, it's 18% of the population had at least a 2 points decline of MoCA compared to baseline.
yeah, that's impressive, particularly how young the population was. Were you expecting that?
In fact, it's a little higher compared to what we did expect. And what we saw also, because we did publish the baseline result last year, and we saw that at baseline, for example, 20%, between 10 and 20% had a MoCA lower than 26, meaning that they have mild cognitive impairment, and that the MoCA score was lower in patients with persistent compared to paroxysmal atrial fibrillation. So there is something. But anticoagulation is not the answer in this population.
That's interesting. And the rate of stroke was quite low.
The rate of stroke was just,
what we would expect.
Exactly.
Yeah.
Because, depending on the trial, it's between 0.5 to 1% a year. So in this trial, it was 0.8% in the placebo group. So it was low. But the rate of major bleeding was also pretty low, lower than 0.2% in this population.
Wow.
So.
And you used a lower dose of rivaroxaban, though, right?
Yeah. That's correct. Yeah. That's correct. So we use 15 milligrams to minimize bleeding. We had very few bleeding in the trial, no fatal bleeding, and we use 15 milligrams. That's correct.
Yeah. I mean, in some ways, it supports what we do clinically. It's always difficult when you see a young patient and doesn't have any risk factors, and we know the guidelines say not to anticoagulate, but we really didn't have data necessarily in that young group of patients, so this is a really important study.
I think it will. It raises also a lot of questions.
Yeah.
What can we do to decrease cognitive decline in this young population? Because we are seeing there is a cognitive decline.
Right.
And also, the stroke rate is low, it's on 0.8, but could we, better, define which population would need anticoagulation in this population? So those are all the questions, we want to
and you'll
answer.
Be able to do that, right?
We will be able to answer a few and to also to generate hypotheses, because what we did during the study is we collected biomarker during the study, EKG, echo data. We have the left atrial volume, so the atriopathy thing is huge. So we will be able to look at that, but just from the size of the left atrial volume.
Sure.
We have genetic testing, and we also perform cerebral MRI in a part of the population. So it was not possible, obviously. We would have liked to get MRI, at baseline and in follow-up for the whole population, of course. But because of funding issue, it was not possible. So what we did is we did MRI in all patients who reached the primary endpoint, and we did MRI in a subset of patients who did not reach the primary endpoint.
That's great.
So we will be able to answer some questions.
That's great. How many MRIs did you
So
get?
we have a little more than 350
that's
MRI.
great. Yeah.
Yeah.
So you could look at some correlations with
exactly.
the MoCA score.
What we want is to understand is there is a difference in the brain in those who had the decline and those who not, because you could argue you give anticoagulation, it's good for the
right.
to decrease the microemboli,
Right.
but it will increase microbleeds.
Right. Right.
That's
yeah, exactly. And it was interesting the point that Eric Prostowski made, and I have seen this as well, that some patients report that they don't think very well when they're in atrial fibrillation. What you said about the patients who are in persistent AF having more decline, I wonder whether we should be thinking about looking at that as an endpoint in rhythm stabilizing these patients.
I think it is important for the patient.
Yeah.
I mean, we all have patients who say, no, I don't think clearly.
Yeah.
I'm slow when they are in AF,
Right.
and as soon as they are in sinus rhythm, they think clearly. We all have patients like that.
Right.
So we need to know, which medication. Obviously, ablation is important, but we cannot. Ablation does not work for everyone.
That's right.
No, we have patients in the trial. We have 22% with persistent and permanent atrial fibrillation. A young patient with permanent atrial fibrillation, ablation won't work.
Right. Absolutely.
So you still need to find other ways to decrease the cognitive decline.
Yeah. So when you stop the trial, all the patients go off anticoagulation, then or does some stay on?
So when we stopped, there were no sign of harm.
Yeah.
In the trial, this is very important.
Right.
The major bleeding was 0.2% per year, no fatal bleeding. So we had a conversation with the patient, and depending of the patient choices, the age, obviously if the patient will reach 65, so it was really a personalized discussion with each patient of the trial.
Right. And do you think maybe, would you follow these people longer? Are you going to have a post-trial follow-up and look at some of these events?
I don't think we will do that because they stop the medication.
Right.
So I think, and some patients want to get anticoagulation even if you tell them it doesn't work for cognitive decline. They believe they want to. So it will all mix up, the groups. That's not like ablation. It's medication. You have to be on that. Yeah.
Right. So what is your next step then in the study data?
The next step is to analyze a huge set of data we have. Mm-hmm. So what we collected more than 5,000 MoCA tests.
Wow.
That's
a lot.
That's a lot, believe me.
Yeah.
So what we want, and biomarker, DNA, and everything. What we want to do is to be able to find which population, as a decline. Cognitive decline. So if we are able, to do so, and also we want to look at, for example, we have a lot of patients with sleep apnea. Does it impact, cognitive decline? We have patients with ablation, AF ablation during the trial. We have all the medication. So that's one part, being able, to narrow. What subset of the population is at risk. Yeah. And the second is also to work on the risk of stroke. Mm-hmm. Obviously, it's the rate is low. It's a low number, but it's brain AF is a very pure population. Right. You have data from Sweden. You have data from low-risk patients, but they are all from database. Right. Right. So we don't know if it's really low or just because of the high. They didn't. We have the BNP. We have the biomarker. So we want to work on that too. Sounds like a fascinating data set. So I think more work ahead. Sometimes sometimes you do the primary results and we learn so much even more from just all the data that's collected, and particularly about cognitive decline. That's a unique data set. Well, congratulations. Thank you. Anything else you want to say about the trial? I think we cover it. All right. Well, thank you. Thank you.